Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Chaitu Malempati from Kentucky, United States. After completing his residency from Michigan State University, Dr. Malempati pursued fellowship training at the University of Kentucky. He's been fully board certified since 2019. Dr. Malempati is head team physician and medical director of the Western Kentucky University Athletics, and he's also vice chair of surgery at the Medical Center Bowling Green, and also serves as counselor for the state of Kentucky Southern Orthopedic Association. Dr. Malempati is also technology committee member for the Arthroscopy Association of North America, member of the nominating committee of Southern Orthopedic Association, and enduring education committee member for the American Orthopedic Society for Sports Medicine. Dr. Malempati has several high-impact publications in sports medicine journals, and he has presented his research across meetings in the United States. So today, it's my great honor to introduce you to Dr. Chaitu Malempati from Kentucky, United States. Over to you, Chaitu.
Thank you, Hitesh. And thank you all for, it's quite an honor and humbled to be able to talk to you all today. We're going to talk about distal bicep tendon injuries today. Obviously less common than proximal bicep injuries, but nonetheless, especially in middle-aged males, laborers, definitely an injury that we see, especially in the sports medicine setting. Here are my disclosures, nothing directly pertaining to this talk today. So starting with biceps anatomy, so the biceps brachii is the primary supinator of the forearm, approximately 15 to 30% supination strength comes from it. It also has a secondary role as an elbow flexor, and the functional attributes follow the anatomy. So there's two distinct origins, obviously. The short head attached to the coracoid process and the long head attached to the supraglenoid tubercle and the glenohumeral joint. So the insertion onto the radial tuberosity is a single functional unit, different from the origins, and the footprint of the attachment is at the apex of the bicipital tuberosity when viewed in the coronal plane. Down at the bottom picture, that's a good view of anatomically the anatomic attachment and the footprint of the biceps tendon on the tuberosity. The radial tuberosity is offset ulnarly from the axis of the radius when the forearm is fully supinated, dorsally when the forearm is in neutral rotation, and radially when the forearm is pronated. What this means is this anatomic relationship allows the contraction of the biceps muscle to create a cam effect to produce supination of the radius. The effect of an offset biceps attachment is most pronounced and easily palpated when the forearm is in a neutral to fully supinated position. So distal bicep tendon injuries account for approximately 3% of all biceps tendon ruptures. So obviously proximal ruptures are much more common. They tend to occur in middle-aged males after an eccentric load is applied to the elbow. Sometimes patients will commonly come in saying that they felt a sudden, sharp, and a painful tearing sensation in the antecubital region. And usually when you are able to assess these patients in the clinic, there's a palpable defect there at the radial tuberosity where the biceps insertion should be. So on physical exam, there's typically some bruising in the mid upper arm down to the elbow region, significant soft tissue swelling. There's usually a palpable defect, especially in complete and full thickness ruptures. And the hook test is a good diagnostic exam maneuver to assess this type of injury. Going from lateral to medial, just proximal to the elbow, you can often put your finger and hook underneath the biceps tendon. On imaging, MRI or ultrasound can be used to distinguish between partial and complete tears, especially when there's suspicion on physical exam. In my setting, I like to use MRI. I think it's pretty accurate, and it gives me a sense of, especially in full thickness tears, the amount of retraction. So if there's significant retraction, I'm thinking that I may need to make another incision proximal to the antecubital region to find that tendon. If there's any retraction, I usually try to get to these sooner than later just to make it easier to get that tendon back to its native footprint. Indications, operative and non-operative. Non-operative treatment typically results in some loss of flexion, supination, strength, and endurance. Non-operative management includes anti-inflammatories and physical therapy to reduce the pain and swelling. Physical therapy obviously focuses on elbow and flexion and supination, which is the main functions of the biceps. According to a study by Mori and JBJS, the loss of the distal bicep tendon attachment can have up to 30% loss of flexion strength at the elbow and 40% loss of supination strength in the forearm. So partial tears, partial thickness tears, partial tendon ruptures, and mild tendon ruptures both can be treated the same. You can proceed to strengthening when there's full range of motion, and obviously operative intervention when non-operative management fails. Typically, these patients, after 3 to 4 months of observation, can be very functional and gain their strength with flexion and supination back. In these patients, typically their main complaint is pain as opposed to weakness. Operative management typically indicated in active patients, athletes, obviously, and laborers. Basically, anybody who won't be able to tolerate that 30% loss of flexion strength, 40% loss of supination strength in terms of their daily living, their job, and their functional activities. And with operative management, early anatomic reattachment is the goal before that tendon retracts too far, making things more complicated. So surgical technique, I'll talk about, how I treat these in my hands and my surgical technique first. Typically, the patient is supine. We're using an arm board and a tourniquet. And I like to make a 4-centimeter transverse incision, 3 to 4 centimeters distal to the antecubital fossa. I know some describe a longitudinal incision as well, but I feel like a transverse incision gives me good access to the radial tuberosity, allows me to find that distal bicep tendon, and also decreases any iatrogenic risk of any neurovascular injury. That the former S-shaped incision, I think, has kind of fallen out of favor, typically because of the higher complication risk with neurovascular injury. So I make a 4-centimeter transverse incision, 3 to 4 centimeters distal to the antecubital fossa and the elbow crease. The main structure of importance initially on exposure is the lateral antebrachial cutaneous nerve, and that needs to be identified and carefully retracted laterally. I like to use a simple Army-Navy retractor for this. Then make an incision through the fascia carefully and bluntly dissect the pathway to the biceps tendon, and you can feel that and palpate that. Obviously, I have one assistant keeping the forearm supinated the entire time. That allows me to identify the tuberosity pretty easily. That's the best way to find that distal bicep tendon, and that keeps the posterior interosseous nerve out of the way during the surgery. So the distal biceps tendon is then retrieved into the wound with blunt dissection, and flexing the elbow can really aid with this. You can also massage the muscle belly, and that can help deliver that tendon distally to make it easier to find. I like to place a retractor anteriorly to elevate the tissue of the distal brachium, and that helps with exposure and finding that tendon. I'd say in about half of cases, I find that there's some fibrosis there or some scar tissue, and that may need to be relieved or split apart so that that tendon can be released. If the tendon can't be found, then a second incision, 3 to 4 centimeters proximal to the elbow crease, can be made, and that can help in aiding that tendon, aiding in finding that tendon, and then tunneling it down to the distal incision at the radial tuberosity. So first, when we find that tendon, we typically tag it with an Alice clamp so that we can identify it, and then we remove any significant scar tissue so that can easily be introduced into the socket that we're eventually going to make. And then I use a number 2 non-absorbable suture, and I use a locking crack out technique or any locking stitch format. And I typically, in a locking format, so the distal 25 millimeters of the tendon. That's I mark that area, and typically about anywhere from 10 to 20 millimeters of that typically goes into the socket. So here, a picture here, after I've whip stitched the tendon, I'm sizing the diameter so that I know the size of the socket I'm going to drill. Typically, males and females, it's around a 7 in diameter. So once I've done that, I use fluoroscopy to locate the anatomic distal footprint on the radial tuberosity. Here, my freer is in pretty good location at the anatomic footprint of the distal biceps insertion. And then I drill a bicortical beef pin across both cortices, the near and the far cortex. And then I use a cannulated reamer that's equivalent to the size of the diameter of my tendon to make my socket. So I use a line-to-line fit and technique. And so if my tendon diameter is a 7, I'll use a 7 millimeter reamer. And obviously that 7 millimeter reamer is going unicortical, not bicortical, and that creates the socket to introduce our tendon. So then we attach the biceps button to the distal tendon that's been whip stitched, and with an introducer, introduce it into the socket, and the button then goes out through the far cortex and is flipped appropriately. Then the sutures are toggled, introducing that tendon into the socket nicely with a good line-to-line fit. In my hands, I did use a interference screw as well in the past, so I would ream a 0.5 millimeter larger than my tendon diameter. But my level 5 evidence is that I think the line-to-line fit that I've been getting, I feel like that's been getting equally good fixation, and the patients have been doing very well. Once that tendon is introduced into that socket, you can then take one of the limbs and sew back over the tendon, being careful not to disrupt the locking stitch format, and that'll lock that tendon into place. And then obviously to make sure that that button is flipped on the far cortex, we confirm with fluoroscopy, and then we directly visualize and palpate that tendon into the socket. Postoperative rehabilitation. So phase 1, 0 to 3 weeks, we typically place them in an elbow range of motion brace, locked in neutral and worn at all times. Basically start some gentle wrist and shoulder range of motion exercises. Phase 2 is 3 to 6 weeks, active extension to 30 degrees in the brace. Continue the wrist and shoulder range of motion, no active flexion, and gentle joint mobilizations. Phase 3, 6 to 9 weeks, we begin active extension to 0, maintain wrist and shoulder flexibility, and we actually begin some rotator cuff and deltoid isometrics, and then progress the active extension in the brace. Phase 4, 9 to 12 weeks, gently advance range of motion to tolerance and begin active flexion and extension against gravity. And you can advance the strengthening in phase 3, from phase 3 to resistive, but continuing to maintain flexibility and range of motion. And then phase 5 is 12 weeks to 6 months, gradual return to full motion and pain-free motion, begin gentle flexion and strengthening. And once there's full motion and strengthening, we can then advance to all activities and return to full activity. Complications. Re-ruptures are pretty rare in most case series that have been published, irrespective of the method of fixation. The classic 2-incision technique that I think has been more replaced with the 1-incision technique lately. Possible complications: heterotopic ossification, radial ulnar synostosis. And radial ulnar synostosis can actually be prevented by limiting dissection of the ulnar periosteum. Other potential complications with the 2-incision technique: stiffness, posterior interosseous nerve palsy, and bone tunnel fractures. With respect to the single incision technique, some complications are lateral antebrachial cutaneous nerve palsy, which is actually the most common, which is important why it's important to identify that and retract it laterally when making the initial approach. Posterior and Ross's nerve palsy, that can be avoided by making sure the socket is drilled with the forearm in supination during the, and really the forearm being kept in supination during the entirety of the procedure. Some other complications: re-rupture, stiffness, anterior elbow pain, radial ulnar synostosis, again, that can be avoided by limiting dissection of the ulnar periosteum, and then complex regional pain syndrome. Looking at outcomes, the endo button method of fixation has actually been shown to have the highest ultimate tensile load. Some clinical studies with the endo button have also demonstrated good results with fewer complications. Other methods are suture anchor fixation or interference screw fixation, which I discussed earlier, that I actually used to do before I did line-to-line fit with a button. The tensile load strength and the complications of clinical studies, actually Mazzocca and his group with Romeo evaluated 4 different techniques of distal biceps tendon repair, published in AJSM, and they found the endo button to have the highest load to failure. And there's a couple other articles that have echoed those results. Looking at other outcomes, patient-reported outcome scores, such as the disability of arm and shoulder and hand, and the Mayo Elbow Performance Index have been used, and many studies have demonstrated excellent results with primary repair of the distal biceps tendon. The objective data, including strength testing, have also demonstrated good results with anatomic repair, especially with regard to restoring supination strength. So a non-anatomic repair can really affect supination strength. So it's important to use fluoroscopy to know the anatomy, know where the anatomic attachment is, and try to recreate that with the tunnel or the socket. Chronic repairs and reconstructions have also performed well, although the results are obviously not as good. The tendon quality usually isn't as good. Usually you need a graft and some sort of allograft, and there's typically significantly more retraction in these cases. Obviously, there's a higher complication rate. Thank you.
Thank you, Chaitu, for that brilliant and crisp presentation. Just a few questions.
Yeah.
Now, when you get your fixation to the radial tuberosity, at what flexion level do you keep the elbow, and what is the supination pronation at what angle to get into the correct isometric point?
So I typically do it at 30 degrees of elbow flexion, and I try to I drill that socket at neutral rotation.
So you keep it mid prone, right?
Yes.
And you check it with the fluoroscopy and get it right.
Yes. And then I make sure in range of motion, I'm obviously not testing 0 to 90 or anything like that, but 0 to 30, 0 to 45, I'm making sure that tendon's fixed solid and there's no movement there or toggle.
And have you performed the dual incision technique? I mean, is there a scenario where you want to put a dual incision?
Yeah, so in my hands, I've not went into surgery with the plan of performing a dual incision technique at all. I feel like that 4-centimeter transverse incision distally gets me good exposure. The only time is when there was some more significant retraction in this patient, I think about 6 centimeters on the preoperative MRI, where I actually couldn't get the tendon, and I had to make another incision proximal to the elbow crease just to find it and tunnel it down. But I think the single incision technique has worked well. And I think, a couple nuances and important steps in it, but I think it can be reproducible and pretty easy to perform.
And post-op immobilization, or what kind of brace? I mean, you showed the proper protocol phase-wise, but what is the kind of brace that you use?
So there's 2 options. I think if there's a patient that I think is going to be more apt to not follow instructions, or I don't trust so much, I put them in a posterior mold splint, a plaster splint that's going to stay on until they see me in the office in 2 weeks. And I typically put that in neutral rotation with the elbow in at about 110 degrees of flexion to take tension off that repair. If there's somebody that I trust more, I may be more apt to put them in an elbow range of motion brace that they could actually take off. for shower and such, but I typically keep that at about 90 to 100, 110 degrees of flexion and neutral rotation.
And extension is something that is going to be difficult, right, to attain, because flexion, you already keep it in high degree of flexion. So what is the normal time limit where you, expect complete extension?
Yeah. So, if it's an older patient, lower demand, obviously it's going to take a little bit more time. I think those people, I think a good goal is to get that back at 10 to 12 weeks. If it's a younger, more active individual or a laborer, I expect them to get that more back at 6 to 8 weeks.
And have you encountered any complications, or what are the difficulties in the post-op period that you have encountered in your series of patients?
Yeah, so typically it's the numbness in the lateral forearm, and that's common. Even if because I've had some where I've identified the nerve, I know I've retracted it. I'm using an Army Navy. We're not injuring the nerve, but they still have some numbness in the forearm. But that typically goes away at about 4 to 6 weeks. But I try to tell them that beforehand, preoperatively, and make sure they understand that there's a likelihood that they're going to have some forearm numbness.
And any case of loss of fixation or something like that?
No, I haven't had any, knock on wood, but I did use the interference screw. I like that technique, but I felt like this line to line was just a better fixation because the interference screw sometimes that doesn't let as much tendon get into that socket. It kind of pushes it out. And then sometimes that interference screw can also sit proud or break. And so I felt like, getting removing those variables and this line to line fit, I think works really well.
Now, just one last question before we wind up. Suppose we are planning to do an interference screw fixation, and like you said, if your graft diameter is 7 millimeter, you would like to dream like 7.5. And in that case, what is the size of the screw that you would prefer? Diameter.
Yeah. So I think there you would be more apt to put like a size 6 screw, 6.5, something like that. Obviously, one that's going to give that tendon a chance to get into that socket too, where there's not only sutures in that socket. I think you would definitely downsize that screw to get most of the tendon in the socket as you can.
Okay, Chaitu, I think that's all the questions that we have, Chaitu. Thank you for the fantastic lecture. And I know that you're a very busy surgeon, but still we would really look forward for some more lectures from your side, because given your work on a lot of variety of sports medicine problems.
Absolutely. I'd be happy and honored to talk anytime. Thank you all. Thank you, Hitesh.
Thank you very much. Bye-bye.